Cancer is killing thousands of Ghanaians every year, not because it can't be treated, but because most cannot afford treatment. Today, I sit down with one of Africa's most respected oncologists, Dr. Verna Vanderpuye, to discuss these things. Why cancer treatment remains unaffordable in Ghana, why early diagnosis is rare, how religion affects health outcomes, and what we can do to prevent needless deaths. Guys, this conversation might save a life. Hello, beautiful people. Welcome to ChitChat with AkuyeDede. Today's discussion is deeply personal, deeply urgent, and long overdue. Africa has some of the world's most brilliant health professionals, yet millions struggle to receive adequate care, especially cancer patients. Treatment is expensive, early diagnosis is rare, and families are left bankrupt or helpless. And while the US relies on insurance to access medical care, Ghana's system is mostly cash based. If you don't have money, you're in danger. And some of the times, the people with money go outside Ghana for treatment. Today, I speak with one of the world's renowned oncologists, Africa, United States, UK. Her name, Dr. Verna Vanderpuye. Welcome, welcome. Hey guys, welcome to Chit Chat with AkuyeDede. Guys, today I have one of Africa's finest oncologists, Dr. Verna Vanderpuye. Hey! I can't believe it. I just can't believe this. I'm so honored to have you here. And I'm glad I'm not seeing you for the reasons why people come and see you. Uh-huh. So, first question though, why is cancer treatment in Ghana so expensive?
Cancer treatment is very expensive everywhere in the world. What masks it is because you have some financial protection from health insurance, but don't forget that cancer care is the number one cause of bankruptcy, even in the US. That's what people don't know. The out-of-pocket payments are actually quite high.
Wow.
Yes, but people don't say it, but if you go and do your research, it's actually the number one cause of bankruptcy. For us, because most of the countries also don't provide full financial protection also. So even though comparatively it's cheaper, but the out-of-pocket cost for us is quite huge. So I think we are even thinking about launching out something more like tourism, medical tourism for Africa, because it's so much cheaper to get treatments here. You're looking at it in cities. Right. It's in dollars. You realize that it is so much cheaper. Almost the same quality of care. So I think that's something that can be shaped up, and I think something that we can really look at.
Wow, I didn't know this. Guys, I didn't know this. I told you we're going to learn a lot today. Wow. So in terms of Ghana and other African countries, what's the comparison in terms of costs?
I think it's almost the same.
It's almost the same.
Yes, there are a few studies that have been done in the different countries, and it's almost the same. There's some place like Kenya, very good health insurance, national health insurance.
Oh.
So therefore, the out-of-pocket costs. There was a study that was done by Olusegun and Co. And they looked at Kenya, Ghana, Nigeria, and then one more place.
Right.
And Kenya, they looked at everything from diagnosis to treatment. And the out-of-pocket cost for Kenya was one of the least, just because they had health insurance. But you see, the healthcare cost is not just the direct healthcare cost, but also the out-of-pocket cost.
Yeah.
So, which is like the indirect, like taking time off work, and transportation, extra caregiving help. Those are the things that we don't really look at, but that actually also blows it up. But then in Africa, I mean, most people actually have to sell property. The family has to sell property. There's a lot going on with the cost of care for low to middle income countries. So we're hoping that the WHO has launched the universal health care. Almost mandatory for countries. The problem is that where is the money?
Yes.
It's something that has to be figured out because it's quite sad. And also, not just that, the cancer care is becoming very expensive because of the newer drugs.
Big pharma.
The big pharma. So the problem is the benefit, how much benefit is it? But if I had the cancer, I'll take that 5% benefit.
Right.
The truth of the matter. And unfortunately, that can cost. And these
Right.
drugs are not like for 3 months, 6 months, they are for like the rest of your life. And you know how it is now with cancer, people are living longer. So you might be on for another 2, 3, 4, 5 years. So overall, it makes it, very, very difficult. Where we are now is very difficult. So we really have to talk about cost benefit issue. And what is important. Not looking at, sometimes we also look at the survival without looking at the toxicities.
Yes.
The quality of life with it. So those are the things that need to be balanced out. Yeah.
Huh. But I wonder if the average Ghanaian thinks of that.
No.
Because it comes to my next question. I mean, why do many Ghanaians seek medical help only at the late stages?
So it happens to even doctors. So let me tell you that. So you see, it's in our DNA. That's what I say. You see a lump and you bind it and you pray about it and say it's nothing, or let me wait for another month or 2 to see whether it goes away. I think that's just how we procrastinate a lot and say it won't happen to me. It's like we are so strong faith and think it can't be me. No, this is not it.
Right.
You understand? And then you have also the charlatans. Forces. So don't go to the hospital. There's nothing to say about it. You understand? But God gave us wisdom. I have a joke. I said, you know why this is so hard? Because it is so important. So God gave it a hard shell. You have to use your brain. That's what controls the rest of everything.
I like that.
I like that. Very
challenging, because people, we had my friend who refused help until the very last.
Sometimes I'm not too judgmental, because I think that when it comes to your turn, you might actually do the same. That's what I
really.
Yes. So I think it's also about femininity.
Okay.
Keeping your breasts.
Right.
That is the first thing. But as we have more like reconstructive surgeries and other prostheses, you might see people walking around and you have no clue they have no breasts.
Wow!
Because their prosthesis look so real. And it is so important to coach my patients to say, go and get a prosthesis. Not just saying, the surgeries can be expensive. They are also good, but there are other prostheses, soft silicone. It looks almost exactly as your breast. I joke and I say, where in the night, your husband would know the difference. But
so it's something you can.
Psychological care.
Right.
So just to feel yourself and back to life. It gives you that drive. That positivity is very, very important. So the thing about also delaying is also the access to care. Most of us in the urban areas, it's so much easy to go to a hospital and then be referred to the hospital. The problem is also the knowledge of the healthcare provider. They have a lot of empathy, so they don't want to think it's cancer. That's the last thing they think about. So our index of suspicion is so low. You see a mass and the first thing you think is that it's benign. But if you have over, let's say 35 or 40 and you see a mass, you need to have it in the
examined. Go and.
People don't like to biopsy, and the biopsy is the only thing that will tell you. Put a needle in and look under the microscope.
But people are afraid to do that.
People don't want to do that.
It's
expensive? They think it's a bother. Or the patient says it's too much work. Why do I need to do that? It's not necessary. But cancer, there are 110 types of cancer, even for the breast. There are so many types of breast cancer. Yes, so you need to know which type it is to be able to target. If you hear people talking a lot about personalized care cancer now, because you express a specific marker. So you all have ER/PR positive breast cancer, hormone receptor. But some of them the ER is high. There's HER2 positive. There's KI. I mean, there are so many factions to it. Yes, so they are different. So
I didn't know this.
No, your breast cancer is really the same. Everybody is different.
That's a different strand of it.
Different categories and treat to the best of what you have available.
Right.
Yes, and I'm confidently sometimes what is available. Luckily, breast cancer is on the National Health Insurance. A lot of the treatments for breast cancer. So breast cancer, I would say, has been lucky.
Right.
So the others,
unlike others, right.
I mean, I was even complaining that the women left the children behind, in favor of their breasts.
Yeah.
Some of the children's cancers are also on.
Yeah.
But I think you can also understand the economic, landscape is also very different. There are so many competing interests, schools. Like when I talk to my international colleagues, they say, why can't you guys have everything like we have? And I said, because you don't understand that the kids are still in school under trees. The portals are huge. There are so many competing things. So prioritization is so difficult.
But how do you shortchange health? Because
because health is nobody talks about the economic cost of cancer.
Right.
the women are the workers,
Right.
both informal and formal,
Right.
and then taking care of the homes. Most countries, it's the women who actually drive the economy.
Yes.
Informal work that you are taking for granted, the cake seller, the yam seller, you're taking it for granted. But they are ones who actually indirectly, produce the human capital for the countries, and everybody
There
just
you
forgets
go.
that.
There
So then
you
they
go.
lose their jobs. That time they are in treatment, they can't travel.
Right.
They can't go to work. They have to get someone to take care of their kids. Their kids can't go to school. So it can be quite tough. So
Right.
the cost of cancer care, it has to be matched against the outputs
Yes.
of the woman.
Yes.
And each country is in context. It's totally different.
Hey.
So these are some of the things that we
You have to
haven't got the
face.
statistics for
Oh,
Ghana.
okay.
Other countries have done it.
It must be tough for you as an oncologist to watch why someone will come to you at a late stage because of financial and
There
economic.
was a lot of. It was so easy to say, "Oh man, you should have come earlier,"
But we
we're
don't
not
know.
supposed to say that anymore. You need to have some empathy. You haven't understood. I learned a lesson from a patient of mine. He said, "You have to understand me to help me." That's
Wow.
where I'm coming from. If you know that I'm coming from, to come for the treatment, you'll be screaming at me that I didn't come last week.
Yes.
You don't know what it takes for me to come. My transportation, the things that happen in the background before I can come for treatment. You understand?
Right.
These are some of the things that you can't really just say, "Why are you now coming?" You're too late. You understand?
Yeah.
That's the first thing that pops in our mind. I won't lie to you, but you also have to have that empathy and
Right.
look at the patient's background and find out where can we mitigate this. Where are the pathways that can be improved to make sure a patient who's seen with breast cancer in the village is transported to the teaching hospital, unfortunately.
Right.
Or what is the knowledge
Right.
of the intermediary health personnel to recognize the possibility of the cancer and then direct the patient and navigate the patient to the correct treatment point, the first treatment point, even just for diagnosis. Like I say, if the patient is diagnosed and they decide not to do anything, at least you did the diagnosis.
Right.
Just it's nothing. That's what happens a lot.
Right.
Nothing is nothing by the time they realize it's something really big.
So half the time they don't even know they have cancer.
Exactly.
They just because I noticed something here. People wait till they're sick before they go and see, and even that to get them to go to the doctors is a problem. So how would they even know? So the intermediary that you mentioned, how do we talk to them? How do we train? Do they need extra training?
Yeah, so it's a package that comes with the National Cancer Control Plan.
Right.
Yes, where we have navigators and set up small clinics. You have to educate the healthcare staff that when you see a blue pupil in a child,
Right.
it's mostly retinoblastoma. You understand? They are the first point of call, but we are looking at the nurse in the district hospital. No, it's the CHIPS compound at the first point who will see, and even we call them like they are volunteers.
Right.
Okay, so like in the churches,
Right.
we look out for a lump in the child's neck, and you understand these are that's where we need to be.
Right.
So I think the child cancer program, I think it's part of the WHO or something. They've come together and they are starting from the community level for early diagnosis. The problem is that most time by the time they get to the treatment, the parents decide to do something else.
Oh, jeez.
So that's also another problem.
I was going to get on that. If there's a cultural belief that cancer is a death sentence, and also how do the stigmas? Life is a death sentence.
Because there's only one sure thing in life.
Death.
You're going to die.
Oh my God! You're speaking to a hypochondriac. Oh shoot!
There's only one sure thing in life. The question is how and when.
When?
So that is what makes it a little bit different. I always tell my patients, there's no guarantee I'll be here next week. Don't take it for granted.
Oh my God! But it's true. But
because I see it in the caregivers.
Right.
Oh, where's your brother? Ah, doc, he died last week. He had a stroke. You understand what I'm
Really?
so take it, for. But I mean, don't forget that your caregiver might actually outlive. Your patient might actually outlive.
But it happens a lot, though.
It happens a lot. So that's the things that we do. That's why they say survivorship is one day after diagnosis you're a survivor.
Right.
But so many people who don't have cancer diagnosis are probably even going to go before you. You understand? Yes. So just because it's cancer, you have cancer, so that people don't want to talk about it. They are hiding it. But then the support care helps a lot.
Because
But right now, it's like it's either your mother, your brother, your sister's father's friend,
Right.
your brother-in-law, your sister-in-law, your cousin, your next-door neighbor. So right now, it's with us. I think it's something that we need to. My neighbor across from me said, "Oh, well, did you know that's a job I did?" I said, "No, my goodness, cancer is so common. Everybody has it." You understand? And she's
the big C.
educated, so
Right.
you can just see that it's with us. And I think we just have to. It's now a chronic disease.
Yes.
People are living longer when it's detected earlier. So, like prostate cancer, for example, it starts early.
Right.
Maybe another 20 years, it might become metastatic. So it's a chronic disease. Even breast cancer, people are living with breast cancer for years.
Right.
It's a chronic disease.
Right.
So let's look at it as hypertension, diabetes.
And not see it as a death sentence. The
The
scary.
death sentence comes in when you come very late, or a type of cancer. There are some cancers that are difficult to manage.
Right.
Then the death sentence comes in.
Aish.
You understand? So that is those are what the issues are.
Hey. So the stigmas, the myths and fear, how do they influence the
That's
health
big time.
decisions?
That is big time, and even the highly educated are the worst.
Yeah. I'm finding that out.
Are the most health illiterate. It's very sad.
Oh.
So you see that managing director, CEO, and get their whole attitude to the health-seeking behavior.
It's bad.
It's bad. So that's why I think it's from our training, our culture. You understand?
Yeah.
You always think there's something out there other than the white man's medicine. I hear that every single day. I want to stop all these medicines and go for the African. There's nothing wrong with the African, but I need the evidence. Most of these things have been evidence. They are evidence-based. That's the only thing. So you can't come and give me a photo and say use it for your person. I said, where is the evidence that shows that it works?
Exactly.
One that I have evidence for is not even 100%. I always tell patients, just try. It's not 100%. But
Right.
I tell you, the drug doesn't work for everybody. So that's where fire will come in, positivity comes in.
Right.
You understand?
Right.
Me, I'm just prescribing what I know will help for you, will help you. But the rest of it, I might not have any control over as to whether it works or not. I can't tell that.
No.
You understand? So that is where the positivity, the mind,
Right.
is the most important thing. So I realize a lot of patients who are negative,
Right.
it's not good.
It's
The
not
positive
good.
mind is
They
very, very important.
But I think some of them are crazy because they claim to be positive and God is working on me, but you're really not working the way God needs you to work on
Well,
what's
I
going
also
on.
forget that sometimes Jesus touched people and they were healed.
Right.
Other times he spat in mud and mixed it
Right.
and touched you. So it's different. You understand what I mean?
Right.
But we always want the easy way out.
Hey.
Why do you want to lose your hair, fatigue,
Right.
expensive? So that is what actually keeps people away from.
Is that?
And it's also good to ignore things. It doesn't. That's the thing. We are good at that, ignoring things and saying,
Oh yeah.
it didn't happen. It doesn't exist.
Cancer doesn't exist. I saw it real time and I don't want to ever see it again. We just pray that we don't get it, but only God knows what we have in us and what can come out. I mean, this thing about religion and delayed treatment.
You
And
know that 1 in 8 women get breast cancer, so it's not far away from anybody.
Jesus, no.
It's not far away from anybody.
I'm a hypochondriac and I'm listening to this. But
But
this
it's into your body.
yeah,
You understand?
yeah.
I'm the wrong person, maybe, because I didn't have mammogram for 3 years.
And you're an
But
oncologist?
that's what I'm telling you, that psychologically also has issues.
Okay.
Yes.
Okay.
You understand?
Right.
I spoke to a friend who told me that what I wouldn't know wouldn't kill me either. She's an oncologist. You know?
Is it that you don't? It's not the fear of the unknown because you're not afraid of it, or you don't want it to happen to you. You don't want to know because you've seen what it does, the devastating effects on people.
Not just that, the treatments
The treatments are harsh.
Yes, they're harsh. But the disease is harsh. So.
Oh my God! And then people will come and sit there and tell you prayer camps, prophecies, deliverance.
But when they are sick, they come themselves.
They don't go to
They
the
come. Yeah.
yeah, and that's my thing. I've always believed that these prophets and all these, I'll heal you, I'll touch you, they will go, right behind you and go and see an oncologist and seek treatment. And yet they'll get somebody's child fixated on their,
It's about the money most of the time and then power. That if they get a positive result to draw more people
Ah.
Yes.
So, do physicians in Ghana regularly treat patients who delay treatment due to faith-based healing? So somebody comes to you and they've delayed treatment, they knew they had cancer, and yet they went to some faith healer, and now it's bad. They've come to you. Will you treat that
You
person?
have to.
You don't have a choice.
No, you don't have a choice. Don't
Wow.
forget that now we are moving more towards patient-centered care. So you
Okay.
need to work with each patient with whatever situation. You
Wow.
understand? If they say you're
Wow.
not going to get treatment, there's nothing you can do. You can just, I say the decision has to be informed. So I need to educate you that these are the chances that if you don't take treatment, this is what will happen.
Okay.
You have to, and then let them decide. So right now, this
Wow.
is where we are patient-centered care.
Hey,
Hard.
I was just gonna say.
Because most of the people in Africa are not educated enough to even understand what
And aha.
but we are supposed to have patience.
A friend of mine, Jules Erowak, Mills Lutrot. I don't know if you know her. Okay. Pink for Africa said to me when she started her journey, she's a breast cancer survivor. And she said she went to some of the villages in Ghana and the women were dying. Their breasts were rotting away, and they did, but that was in the villages. They didn't
That's
know
what I'm
about
saying.
it. Yeah.
Access is a big problem.
Hey, so what can we do about this access thing?
Well, I mean, there has to be a roadmap. That has to be government owned.
Okay.
A roadmap to guide these women.
Government.
But then,
Uh-huh.
of course, why are you bringing a woman to Accra if she can't pay for the treatment?
Yeah.
So all those things have to be put into place. And it's not only the treatment. Guess what? She's leaving her job for 3 months. So how is she going to live?
Hey.
When she doesn't have any relatives in that.
Exactly.
Those are all some of the things that has to be put in perspective.
So we don't have any centers in the villages, or like, let's say Tamale and the little villages, pockets of villages around Tamale. Is there a center in Tamale itself for people to be able to go to instead of coming to Accra?
Yes, someone has a center. Maybe
Oh.
not therapy.
Right.
They can do most, and then when it comes to it, but I think the government is planning to expand.
Really?
Yes. To different parts of Accra.
Okay. So, so do you think churches play a constructive role
It depends
or
on
a
the church.
harmful one?
Because some of the churches are, self-owned,
Right.
and you don't know what the goal of the church is. So you just get more membership and show their prowess. So
Right.
like, give me your disease and I'll heal you.
Hey,
What did you do
jeez.
last night? Some of them are bordering on schizophrenia, I think.
I agree.
It's like God spoke to me, so therefore come.
Yeah.
I'll heal you.
Yeah.
But then healing comes in so many forms. So, like I said, you can be taking the medication and still doing your prayers.
Oh.
It should be together,
Oh.
and it should be evidence-based. What works? Everybody knows that the prayers alone doesn't work.
Right.
Patients who have prayer with their treatment works better than those who have prayers behind their treatment. But it has to be. But also, faith is the evidence of things unseen. So that is where the problem is.
Ah.
Why they say that God is healing you, you might not see the changes in your breast, but God is healing you. You understand? Yes, but then the other thing is that there also has to be evidence of you being healed. So if you go to somebody who's treating you and the breast mass is getting bigger,
Right.
doesn't it click that there's something wrong? Because that's what I do. If I treat you and it's not getting better, I know that my treatment is not working, I have to change. That's
Yeah.
how we work.
Yeah.
Yeah, but if somebody gets, pray, and everything is getting bigger and bigger, and sometimes it even drops off, it falls off, and they think that means they've healed you. That's actually that's actually worse.
Really?
Yes, auto amputation of the breast.
Oh.
When they think that it's falling out, so it means that that's positive.
That's positive, but it's not.
Yes.
It's the opposite.
Yes.
Jesus
Or
Christ.
the cancer and the PSA is going up.
Right.
They healed you. Come on. You understand?
Yeah.
So sometimes that's the.
Oh
so
my
those are
God.
the problem. I always say it's difficult. Faith and oncology.
Yeah.
One day when I properly retire,
Right.
I hope to write a book.
Well, I hope you don't retire anytime soon.
I'm retired. I'm 60. According to government of Ghana rules, I'm retired.
Excuse you.
Yeah.
So who's going to take care of the?
I don't think anybody cares about that.
No. That is a problem. That is a problem.
I will tell you a problem. Hopefully, in a couple of years, they'll solve it.
So what's going to happen to the cancer patients in Ghana, in Africa? You're one of the best.
But he has 60.
You know, but Jesus Christ, what is wrong with the government? Okay, we need to have a conversation with the government.
Yes,
Oh.
anyway, so
Hey,
it's the rules of the
no.
It wasn't like that for many years.
Right, but when did
It
they?
was abused, so they have to find that and then streamline it.
Well, but if you're going to streamline it, don't use age.
Drivers were getting post-retirement contracts and things like that.
Oh, you're right.
Yeah, so I think they just wanted to, and it cost the government a lot of money. You know, because somebody else has to be paid after 60. Other set of people have to come. It's all about the human resource. So that's how we look at it. Other countries are rather like even Nigeria has increased their retirement.
I was just going to say.
Age. Maybe they have money to pay. Or maybe yes, you that is such a
No. This is for me. That to me is like the government shortchanging our healthcare system again.
Well,
You cannot retire people who.
If you're 100% in the university, you'll be able to continue for another 5 years. So if you're like a professor in the university, I'm like a part-time in the university.
Right.
Yes. But if I was full-time in the university in Ghana,
Right.
but that's a choice. You understand? Then in that case, you can work for a little bit longer. So those are some of the issues. So if the healthcare, the teaching hospitals were seen as tertiary institutions,
Right.
then I guess it makes sense. But it should take a while for us.
It's 2025. 2026 just around the corner.
It's a new thing. You know, it wasn't. Nobody really thought it would be a problem. It was practically almost automatic that you would continue for like
Right.
up to 65. I think I had to continue up to 65.
Hey, Ghana.
But we are still supposed to teach. I'm still under the Ghana College of Physicians and Surgeons, so I still teach residencies. But because I'm not directly seeing patients in the hospital, so it's a little bit. You understand what I mean?
I will run. Please don't retire. Please don't. Okay, I think after this we'll have conversations. People will drop comments and people will have conversations. There
But
should
at the same
be
time too, you also have to remember that there's a mentorship.
Right.
To train the next generation. You understand? So I think maybe that's what they are trying to encourage people to do, to make sure that you can train people who can take over, which is the right thing to do.
I
They're
know.
not enough of us. That's the point.
But I was just going to say, with Ghana doesn't have a lot of oncologists, and
There are a lot of senior oncologists.
Senior oncologists.
They have more residents and all that.
yeah, but if I'm in trouble and I'm in Ghana and I have a problem, I don't want to go and see a junior. I want to see a
Well, I'm hearing a
senior.
bit of those complaints lately
Yeah,
that they are seeing too many juniors.
nobody wants to see the
Yeah, but
juniors,
technically, I'll
and
say to be fair, it's a teaching hospital, so the juniors have to be taught. What I see as the difference is sometimes the juniors are the ones who don't want to apply themselves
right.
to get the senior person involved, and they like to just make the decision.
And then they make, and from what we've seen, some of their decisions.
How do you know that? That's not what
I did my research, which is why I wanted you. I wanted to speak.
Now, you know that's a new generation.
The new generation are full. Excuse my language. Are full of crap because they have this. They don't have the kind of commitment to even knowing how to. Yeah, but it's the Gen Z. But this is a developing country, so it makes it even more scary. If it happens in the West, fine. But here, it's a developing country.
I think also, like in our era, when my mentor shows me, don't do this.
Right.
Don't give this drug for this particular patient. I don't.
Exactly.
I don't even dare.
Right.
I'll be scared. But then the new generation will say, why not? Let me try it and see what happens.
And they kill somebody. Do you know how many deaths? And talking about deaths, what percentage of cancer deaths in Ghana could be prevented? You see, while we were talking about this with early diagnosis and all of them.
Then you start almost from the diagnosis bit as well. It's not just from the end. You understand? And I think it is worse for sub-Saharan Africa. The women, the death under 50 is more in sub-Saharan Africa from breast cancer alone.
Wow.
Yes, it's very high. But averted death is not just by preventive reason. So who's talking about weight? Who's talking about alcohol? Who's talking about smoking? Who's talking about obesity and exercise? I'm a bad person.
We're all
understand what I
bad.
mean?
Yes.
And then who is talking about this preventive and
Aha.
diagnosis? Who's saying that if you have a breast mass, it's only when it's taken out and looked at and said it's not before it is not.
Right.
That is how
Right.
you pick up early diagnosis.
Sure.
You understand? What about clinical breast exam?
Right.
So many other things.
Ah.
So when we talk about averted deaths, it has a huge implication. You understand? It has a huge implication.
Right.
It's not just the treatment, actually. It's all the way across the continuum.
Hey. So, because, and in saying that, the question somebody wanted me to ask you was, my Black American friend said, why aren't annual checkups common in Ghana? Is it culture? Is it cost? Or lack of awareness? Exactly.
So it's a bad culture.
It's a bad culture.
Yes.
How do we change
How
it?
do we change It's education.
But you're educated and you don't even do it.
Because I spend too much time taking care of my patients and not taking time for myself.
Oh, for yourself.
That's
Physician, heal thyself. Oh.
That's another problem.
Yeah.
Take time out for yourself.
Yes.
It's very important.
I've noticed that. I mean, my brother is also a doctor, and he can keep going and going and going, and I'm like, does this guy take a break? You guys don't take care of yourselves, and then you can't tell somebody that you take care of.
I have a young budding doctor. She just finished the university, ready to be posted, and she wanted to do something this Christmas.
Right.
Take a break, because this might be your only vacation.
Shoot! Oh my
This might be your only vacation.
Right.
Take a break, yes.
God! Hey. So, do you think a national cancer insurance program is realistic?
Yes, they are working on it.
They are working on it.
It's just our finances, but they are working.
So, do we need things like subsidies, donor programs?
There has to be some taxes, and that's what we don't like. There has to be some taxes. That's the only way to take care of this. There has to be some taxation. Yes, that's what we all don't like. But realistically, that's the only way to do this. But like you said, health is so important.
It is.
So
I think they need to prioritize the. If we're dying,
all the cancers, but maybe the top 5, the top, including children, something like that, to start with, and then see how because cancer treatment is not cheap anywhere.
No, it's not. It's not cheap anywhere. But I just think that the government needs to prioritize cancer treatment, health treatment. Okay, healthcare. Period. But cancer treatment is important. I'll tell you why I started doing the research. We keep losing people our age, younger than us, older than us. Right now, there's no discrimination when it comes to deaths, and a lot of them are down to cancer. In Ghana, I think what I found out, the breast cancer deaths were high, and then colon cancer.
I mean, nobody talks about.
Yes.
We all don't have colonoscopies. We don't check our stool for blood.
Why?
Everything is cocoa.
Hey! Coco. Oh shoot! No, but this is scary.
You don't do. But that's the basic is to check if
Yeah.
your stool and then follow up with the colonoscopy.
Exactly.
So everybody over 50 is supposed to.
It's supposed to do
If
that.
you don't, and it's once in 3 years.
Oh,
Or even sometimes you do it once in 5 years. So that's the thing. And if you have a family history,
you go and
when
right.
everything is cocoa.
Hey.
But sometimes it's just our pocket. We are scared. We think what it
And
could be.
that's what I'm talking. The culture when it comes to how it impacts healthcare is scary. We don't want to go to the doctors unless we're sick. We don't want to know what it's a fear of the unknown. We don't want to know. We don't want to follow up. We don't. Sometimes I think some people use the cost as an excuse. They just don't want to know. People are dying more now than ever. More so now than ever. Why?
No, because you're now being aware of the number of cancers.
Oh. Oh, okay. Okay.
It was more like people were hiding it.
Right.
And then the diagnosis was also, difficult. But now it's like
It's out there.
it's out there, yes. So that's why it's like that.
So, how can diaspora communities support access to treatment in Ghana?
Cancer treatment is very expensive. So I really don't know
Yeah.
how that is going to happen.
So, are they affordable?
I mean, like, there are NGOs that can help.
Uh-huh.
But sometimes they want to bring drugs from outside. It's not cost effective. First of all, outside the drugs are like, like
Terribly expensive.
Yes, the same thing is about a tenth
Right.
of the cost in Ghana.
Oh.
Exactly.
Oh.
So sometimes it's best if you. But even how much can you spend on one patient? You're talking about a lot of money. So I guess I want to take care of this patient's care, and I have to warn them that, my dear, it's not that cheap. You need to be able to make sure that you have, enough money to be able to. And that's nobody's fault. The drugs are expensive. You're talking about generic drugs.
Right.
Out there, there was a publication in the Lancet just recently.
Right.
How sub-Saharan Africa and they have a lot of influx of undocumented drugs. And then the quality is a problem, but because of low cost,
yes,
that's what makes them come in. So those are some of the things that you think you're getting it cheaper, but in actual fact, it's really not working.
It's not working. We're getting crap.
It's not going through the checks and balances that it's supposed to. Maybe to the processes to do the checks and balances are too expensive and too tedious.
Hey.
So sometimes that's what it is.
Okay, this is scary news. I mean, so this is more personal. How do you feel sometimes when someone comes to see you and then in the middle of it, they don't have money and you've started treating them, they can't pay? And
so I think on a serious note, talking about cost of treatment is very important. At your first visit, you really have to address that.
Okay.
You understand?
Okay.
So what I typically tell my patients, I mean, breast is not a problem anymore per se.
Right.
Especially for the first line, second line. When it becomes, further advanced, then it becomes a little bit difficult.
Wow.
But overall, what I tell my patients is that this is what I want to give you.
Right.
But there are like 4 other options. They might not be as efficacious as the first one.
Right.
But just in case you go and you can't afford it, come back to me and I'll give you the other one.
Oh.
What happens is that immediately they are told the cost, they just walk out of the door.
And that's it. Oh,
so that's also another problem.
Right.
50% of people who are referred to the cancer center don't turn up. And 50% at their first visit do not return. So that's also another thing. Sometimes it's just the cost, just that, but then I think it's just the way we put it. And the health insurance for breast is made a lot of difference.
It has. So
but sometimes, even though I run a drug access program for Gleevec, is for a particular kind of sarcoma.
Okay.
And some people it's free. The drug is like $10,000, but it's free for my foundation.
Oh, okay.
I've been running for like almost 15 years.
Wow.
And they even have other drugs on it. They just decide to stop the treatment.
Oh, why?
Why?
Wallahi. Why?
There's this notion that why should I keep taking a drug for so long?
When
you take your antihypertensive,
right?
You take your diabetics. So why are you saying that you eat every day and you need it to survive? But there's this thing about why do I have to take a drug every single day of my life? They don't get it.
They don't get it.
It's the same with hypertension, so they end up with strokes. Because they stop. Why should I keep taking drugs forever? Then they stop, and then the BP just shoots up
and then stroke. Next thing you know, or die. Sorry.
Or short illness.
Oh yeah. Hey, I don't know why people play with their lives like that. Maybe.
Yeah. I think we can start from the young kids.
Right.
I realized when we started the breast clinic in Koliku, I realized a lot of young people were bringing their parents, and I thought that was very interesting.
Yeah.
I heard about breast cancer. My mother has a breast cancer. Can you check it out?
Oh.
I think that's where we need to go. Maybe for kids, you're not going to do screening or anything, but it's rather education.
Right.
You understand?
Right.
So I help maybe the family member who has a lump somewhere, a sore that wouldn't heal.
Right.
You should consider guiding them through the healthcare system.
Hey.
But I mean, there's a conscious effort now to take cancer seriously.
Because
that it will really pan out.
I really hope so, because I mean, what the emotional toll on families.
Emotional, I mean financial. Which one?
There's no difference. It's the same thing. But there's a financial part, but then the emotional part that you're facing, that it's like a death sentence. For me, I know I'm educated. I'm supposed to not think of cancer as a death sentence, but I pray to God I never hear that I have the big C. Because I don't know how it will work on me psychologically. But with you, that's why you can't retire. Until because with you here, oh my gosh. So How do physicians cope emotionally?
It's very difficult. I've just gone through quite a difficult streak myself.
Oh no.
Yeah, it's very difficult because I get very close to my patients.
I noticed
I
that.
get very close to my
Oh, I
patients.
noticed
Some of
that.
the deaths are unexpected.
Right.
Sometimes it's not always the cancer that kills the patient. Sometimes even the side effects of treatment can do that.
Oh, something different.
Totally different. But I know when somebody has a cancer and they pass, the first thing everybody says is he died from cancer. Or it's cancer, so it's okay.
Oh.
So that you don't find out
What it is.
Exactly.
Oh.
So it can be very difficult when I get very.
See.
Some of them, yeah. I mean, it's easier if the patient is very advanced and you know it's coming.
Right.
Even that, when you are close to them, it becomes a problem.
Me, I you know what?
Tough. It can be tough.
Why did you choose oncology? Because
I
of
think it's the
all.
best thing ever in the world.
Why?
Many oncologists will tell you the same, that they won't do anything else.
Yeah.
Now it's becoming more difficult, but there are new drugs,
Right.
new science, new drugs. You have to prove yourself. The drugs are so expensive, the patient can't pay, and then you are confused.
Right.
So now it's getting very complicated. So now the older oncologists are like, really? Do I really want to continue this?
Wow.
You understand? Because it's
Right.
becoming just too complicated now. And I hear even like a friend of mine is in Canada, she's saying they're not even getting new people to start the training program. They're not coming.
Hey.
Oncology is too difficult now.
Yeah, I mean, I don't know.
I mean, the science is so much.
Right.
You need to every day you are reading. Me, I don't play with my iPad. I don't say never.
Right.
Never
Right.
say let's go and search out there.
Right.
You know, to keep up with what is going on.
Exactly.
I tell a patient some side effects are common.
Right.
So I can tell you immediately that it is. Some of them are uncommon. And I wouldn't say what you are saying is not true, that is the side effects of the drug. I will go and check. Because some of them is not the things I need every single day, but apparently they are there. You understand? Yes. And that's how it will help you to help your patients. So
Right.
yes, you know. So like a younger oncologist will just say, oh, it's not, forget it, and then continue. And then you depreciate the patient's quality of life.
And that's what I'm hearing
Yes,
about
and
the
sometimes
younger
too,
ones.
Sometimes you just have to weigh in the two, benefit risk ratio.
Right.
The side effect, but maybe let's just manage it. You understand? Because you need the drug as well. There are no other options.
Right.
You understand?
Yeah.
So, and you need a lot of supportive care. That's why people think that supportive care means end of life. No. The cancer, apart from the diagnosis, it comes along with so many other things, even psychologically. How to cope. You understand? So therefore, you also need the psychologist.
Oh.
Which is a non-pharmacological treatment.
Right.
And sometimes you even need antidepressants because you're not coping with your diagnosis.
Right.
Or the fact that you've been told that your life expectancy is short. You understand?
Yeah.
So that alone can actually make you crazy.
Yeah.
The question is that how to make sure that you are balanced.
Right.
To be able to continue to go to work, take care of yourself, live life to the fullest.
Right.
It can be very difficult.
Hey. I don't know how you do it, and I don't know how the patients do it, but God help us.
I'll just say oncologists know what's up.
Exactly. I was just going to say, because
oncologists are very happy to work.
but you
It's like, you know,
you're a fun-loving person.
This is it.
Right.
This is just it. You know, and you have to learn to tell the truth. Don't hide things from the patient. Tell them. You understand?
Yeah.
How much it will cost for your treatment.
Right.
But let's see if we can get something cheaper that will give you the same outcome. You're giving the person some hope that they are also thinking about the patient, and you understand?
Yeah.
It's very important.
I watched
Because some people
you.
just go online. I want immunotherapy because that is the latest kid of the drug. But maybe immunotherapy will not work for you. Maybe it has very bad side effects as well.
Yes.
You understand?
Yes.
In the hands of somebody who's not experienced.
That experience to
You're
right.
going to get into trouble too. Recognize that this is a side effect, so therefore we have to stop.
Hey.
Or we have to adjust.
Right.
You understand?
Right.
So those are,
Little nuances that come with the issues, and then if you're not experienced, guys, are you hearing this? You better go and see an experienced oncologist. And my people, go and see. Don't be a reactionary patient. Don't wait till you're sick before you go and see a doctor. I just wish we could get into that here, because like in the States, I go for my annual physical. I go for my annual mammography. I go for I have thyroid, so I go for my.
see that.
You can see it.
This is from afar.
That is scary. I remember. I remember.
You have that when you were in school. The time.
No.
But that would explain your hyper.
My hyperactivity. I could have,
Yes.
and then maybe I didn't know
Yes.
because it was in the States, even in the UK, no one diagnosed me, and then in the States, I think it was 2003. I had pains. I don't know if it was my lymph nodes. I don't know what it was. Oh, I went to see the doctor and they told me, oh, you have thyroid. They did the MRI, they did the scans, they did the biopsy. And I thought, for me, even though it wasn't cancer, you're telling me this hypochondriac that I have something that I don't understand. I cried. And then I called my brother and said, don't worry, it's in the family. Wow, look. So
nobody told anybody.
No, nobody told anybody. And that's the other thing. If we can tell, if there's something in the family, it's good to share it and then educate ourselves on it, because that could have driven me. Okay. So do you see a future where cancer care in Ghana is both accessible and affordable? Do you see a future?
Affordable will be difficult.
Okay.
So the newer drugs are expensive. But
Right.
accessible, yes, and that's if you have the universal health coverage.
Okay. So
To some extent, it might not be 100%, but at least. I think the most basic drugs, sometimes chasing on the new medications can cause trouble. Yeah, exactly.
Okay.
So sometimes the most efficient drugs, cost effective. So everything has to be in context.
Yes.
That's what we have to
I'm seeing that. So my last question: what 3 practical things the average Ghanaian can start doing today to reduce cancer risk?
Well, so, there's a lot of talk. We are supposed to expand on our NCDs, non-communicable diseases. Communicable diseases have taken a central stage because of infections,
Right.
malaria. So that has, but also to say infections have a higher incidence of causing cancer. Low to middle income countries, some infections.
Oh, okay.
So not to brush it under, even the cervical cancer is connected to HPV.
Yeah.
So it's an infection that you get infected from a partner.
Right.
So that's one thing that we should all. So guys, just keep on your condoms.
The way in Africa men have children everywhere indiscriminatorily, and then
even apart from having children, they do all kinds of things.
oh shoot!
It's like it's the norm. So,
Yeah, it is. It's very scary. My greatest fear. I remember when I started hearing about HPV many years ago. I was like, God, help us.
Yeah, it's an infection.
It's an infection.
So if it's like a polygamous marriage and one wife has cervical cancer,
Everybody's
most
getting.
likely there's not even.
They got it from.
Yeah.
Oh.
So that's why they're trying to also. What is a recommendation to get the boys, the teenage boys as well?
Oh, really?
They're the ones who transmit it.
Jesus.
So that's another thing.
Oh, I hope you guys are following this.
Cancer actually has an infectious.
Wow.
Cancers like H. pylori can cause some form of stomach cancer.
Hey.
Burkitt's lymphoma can be caused by stepping through the malaria parasite.
Oh my
So there are a lot of
God.
connections as well. And then,
Right.
when the people live in the villages, they pee blood.
Yes.
Schistosoma, it can also lead to bladder cancer. So there are a lot of infections that can.
Oh
Even
my God.
TB,
Right.
some forms of lung cancer as well.
Hey.
Hepatitis B, everybody underestimates it, but it's almost like HIV.
Oh, I know a friend who died from that.
Yes, so that is also
Yeah.
transmittable.
That's also
sexually.
sexually.
Exactly.
People forget that one. Is it that they forget that, or they just don't want to know?
I think we are not making enough noise.
We're not making enough
they
noise.
started with the,
Okay.
Including in the vaccination.
Right.
For the children.
Right.
So liver cancer is one of the first, the highest in men.
Oh,
Yeah, but I think in the next couple of years to start coming down. That actually the statistics is coming down.
It's coming down.
Hopefully because of the HPV vaccination.
Ah.
And the childhood. So those of us who missed that childhood.
Right.
But for the health workers who can easily get it or
Yes.
transmit it, nobody's really screening us or protecting us with these vaccines.
Oh, that is
Beyond
serious.
work life,
Hey.
you have to pay for it yourself.
Oh. But that's not fair.
Correct.
So what's the government doing about this? Well, we need to have a conversation with the health minister, the health
Actually, part of
sectors.
the universal health, the health workers should all
Right.
be vaccinated.
Exactly.
Yeah.
Oh my God. Once again, I take it back to the States. In America, it's different. If you have insurance, every year you're going for your, until I had even after my surgery, my hysterectomy, because I used to have fibroids and it led to me having to go for the hysterectomy. I was still going for, every year you go for a pap smear. So they check the HPV, all STDs. I thank God to date, never had a negative report for that. And I had a colleague whose husband gave her funky stuff. It actually affected her throat.
Oh,
She got throat cancer from the
HPV.
HPV thing.
No, it's through oral sex.
Oh my
That's
God.
how you get through cancer.
Oh, so that's what happened. Oh my God.
But were they 100% sure that that's what it was?
Well, I don't know. The people say all kinds of things. Oh my God. Oh, Dr. Vanderpuye.
So if the male was vaccinated in their teenage,
Right.
they were less likely to have it,
Oh,
or to even transmit it.
right.
But sometimes if you are also vaccinated, it's only not against cervical cancer,
Right.
but also these as well.
Hey, jeez. So if America were dropping the ball over there, what about here? But then I just think there should be a system where patients or people are encouraged to go for these annual exams, get themselves checked. I don't have a choice. I have to go. I go for my mammography. I don't have a choice. I go. I think it's every 3 years or something. I have a biopsy for my thyroid. They do. I mean, I get checked out, but that's because I'm there. If I'm here and I have to pay all that money, or if I lack awareness, I'm dead. Jeez. Okay.
Yeah, so I would say that to viewers, thank you for joining this program. I'll say that if anybody has cancer, suspicion of cancer, somebody that you know, the most important thing is to see an oncologist somewhere along the pathway. It makes a lot of difference. Even if it's just once, it helps to direct your care in an evidence-based manner to make sure you get your best outcome. Not just that, even the sequence of the treatments. Surgery first, chemotherapy first, radiation after, which comes first and not, or whether it's necessary or not, can be determined at this point in time. So I think make sure that you consult an oncologist somewhere along the pathway. And we need to listen to our bodies. We tend to procrastinate a lot. I do it myself. I'm not lying to you. But I think the best practice is to take care of your bodies, have your screenings, help to lower our weights. One person talking, but exercise, diet, keep healthy. I think those are the important things in life. The best things in life are free. So remember, so those are the things that we need to concentrate on. Thank you.
I think I've taken up enough of your time, Dr. Vanderpuye. Thank you for your extraordinary service, because I did my research on you and I'm like, wow. I mean, I call you Verna and I'm like, no, I can't call her Verna anymore. She's Dr. Vanderpuye. For your wisdom, humanity, healthcare must not be a privilege, I don't think. It must be accessible to all. Exactly. And to my viewers, check your bodies, ask questions, get screened early, and advocate for affordable care. Yes, let's do that. And let's also advocate for our oncologists to not push them into early retirement, because
Not early.
For me,
No,
it is
different.
I know, but
America teaches you to work forever. Work till you drop. That's what I think.
well, yeah, we work hard and we play hard.
Work till you drop.
But guys, your life matters. So I hope you've enjoyed this conversation. It's been great. It's been an eye-opener for me. I hope it has been for you too. drop your comments, and I'll leave Dr. Verna Vanderpuye's information if you have more questions for her. Thank you so much. It's Chit Chat with AkuyeDede. Woohoo!